Getting everybody in because we're perfectly on time. I don't want to have to order dinner out tonight for anybody. Okay, here we go. Thank you. Marco, if Marco was going to show the first slide, he might be outside. I want to get him right here. Okay, I'm just waiting for where Marco went. I got to make sure he's here, though, Gene, for the slide. I don't know where Marco went. We have a couple minutes here. I know we want to get started on time, but I just want to make sure our audio video. Marco? Not quite. Okay, Marco's there. Okay. 1 second. He's coming in. Marco for our audio visual. Okay. Okay, thank you, Marco. If I may have the first slide. Well, it's, again, a very great pleasure to present the final session for today on three speakers whom I know very well, and also, if we can have, thank you, yes, Marco put the slide on to make the first point. Our first speaker is Dr. Pingpank, and you saw this slide yesterday, and it's on your handout outside, pardon me, and in terms of the pathway of care, what's not shown there on the upper right hand is the hepatic, what goes beyond the hepatic arterial chemoembolization, bland, Y90 beads, or chemotherapy procedures. And this is where Dr. Pingpank has introduced another very, very important option of hope. One thing that's been said yesterday and countered a little bit by Dr. Ardil at noontime today was the fact that and the observation that although the cardiac complications were much more frequent in the past, we are seeing less and less of it now with the introduction of the somatostatin congeners, namely octreotide and lanreotide. But the bottom line is we preserve our liver. And we've heard down at the bottom right, liver transplantations are being done. But in between the frequent embolizations and the RFAs of the liver and a very good function of the liver during all this tumor burden is a very, very important intermediate step that Dr. Pingpank's work has come to offer. And I'm very excited, and many, I hope you've heard him before, but it's a very exciting piece. It's another option, a very important option. He will speak first, and then Dr. Shaw from Quebec City, Quebec, will introduce an in vitro model for carcinoid tumors and offer some very exciting animal information that's also helping us learn at the research level back to the clinical level. Finally, Dr. Woldering is going to introduce and continue to present very novel work that he started about 18 to 20 years ago on choking off the blood vessels in various ways. And his most novel introduction has been now taking the tumor itself and using it to create the angiogenesis and then doing drug sensitization against the blood vessel growth. And this is pioneer work that he began when very few people believed it. So we're going to keep a very tight schedule, allowing up to 25 minutes per speaker, no more, so that we have 9 to 10 minutes after the session is over. Dr. Pingpank?
I'd like to thank the organizing committee for the opportunity to speak here today. Obviously, preceding Dr. Woltering is a little daunting since his experience is probably more than any surgeon in this room. What I'm going to talk about today is something that's come along after about 15 years of research that went on at the NCI in Bethesda, Maryland. I've now subsequently moved to the University of Pittsburgh, where we're going to try and bring this into more widespread use throughout the United States and hopefully Canada and Europe. In the interest of disclosures up front, the majority of the research discussed here is a result of a combined funding from both NCI intramural research funds in Bethesda, Maryland, as well as a cooperative research and development agreement between Delcast Systems out of New York City and the surgery branch of the NCI. Both the catheter and the combination of the catheter and the drug are under investigation and supervision of the Food and Drug Administration of the United States. Just in the way of background, the way we break down in Bethesda malignant neuroendocrine tumors is as follows. There's a group of patients who have well-differentiated pancreatic neuroendocrine tumors, and in a recent series out of Memorial, in 183 patients, the majority of these patients were rendered NED or without evidence of disease at surgical resection. But if you follow them for a longer period of time, of the patients who recurred, 22 or 76% recurred as a first site of recurrence within the liver. Now, if you look at a slightly more aggressive or a more aggressive group of patients analyzed very recently out of the University of Pittsburgh, looking at the SEER database, and this is a database comprised out of 14 cancer registries throughout the United States, non-functional pancreatic neuroendocrine tumors constitute a more aggressive form of the disease. And at diagnosis, 44% of those patients will already have metastasized to regional lymph nodes, and 60% of patients will have disease which has progressed to the liver at the time of diagnosis. Median survival in patients who have M-positive disease or metastatic disease is 1.5 years, indicating that aggressive therapy is certainly warranted in these patients at the time of diagnosis. And then if you look at carcinoid tumors, which obviously we spent a lot of time talking about this weekend, there's an increase in incidence within the United States, and certainly the presence of metastatic disease varies with tumor size, but in patients who present with primary tumors greater than 2 centimeters, approximately 30 to 50% of patients will develop hepatic metastases. So what is the success, and I'm sure this will be addressed a little more later, what does this suggest for success for a majority of tumor types when hepatic surgery is used in order to render them disease-free? And the top two series show that unlike other tumor types, successfully removing hepatic metastases in these two series quoted here can result in 5-year survivals of close to 3 out of 4 patients, whereas if you look at kidney cancers, sarcomas, breast, and stomach cancers, the likelihood of a long-term cure in these patients is vanishingly small. And again, going to show you that what we want to do is preserve the liver and preserve liver function with aggressive intervention when warranted in patients. Now, obviously, these do not represent all patients who walk in the door, but they're a selected group of patients, and that speaks to surgeon judgment. If you look at how these tumors are managed, so a series of patients out of the University of Wisconsin, which was published several years back, or 2 years back, in 48 patients, and with a mixed group of carcinoid patients and islet cell tumors, non-randomized. So this is surgeon's choice and physician's choice as to what's the best way to manage these patients. The patients underwent an equal amount of resection with or without radiofrequency ablation, chemoembolization, or conservative therapy, and those were probably patients who, for the most part, were felt to be too much of a risk factor either for medical reasons or volume of disease. So again, there's a little bias in the way they looked at it, but the ability, this line is the only line that's significantly different as far as survival, and the ability to get all the disease out of patients to successfully render patients free of disease was what was associated with prolonged survival. Interestingly, in this group of patients, if the endpoint you were following was to simply symptom palliation, all 3 groups had equal palliation of their symptoms after the intervention they had, but only the group that had surgical resection had a better survival. The largest experience in any country in the United States, or any country in the world, with regard to what hepatic surgery can do is the colorectal experience. And this is the largest series in the United States out of Memorial Sloan Kettering. And not to make too much out of this, but there are ways you can stratify who is going to do better and who is going to do worse. And these can hopefully translate into some things that we can look at for neuroendocrine tumors. But if the time between the primary disease and the metastases is greater than a year, so the longer the amount of time between the primary disease and metastases, the smaller the number of tumors, the lower the number of tumor markers, the smaller of tumors. All of those things impact with colorectal cancer the ability to get long-term survivors after surgery. This is, I think, important data, not because it says a lot for any one particular patient, but I think it points to the need to aggressively screen patients who have primary tumors, even if they don't have metastatic disease at the time of their diagnosis, because the earlier you intervene in patients with metastatic cancer in the modern era, the more likely you are to affect a long-term positive outcome. So the group of patients who we've been treating are patients with bilobar, or both sides of the liver metastases. And what are sort of the standards that are out there for therapy, which we use as our baseline to consider? And these are patients who we consider to have unresectable disease. So patients with extensive disease in both sides of the liver, involvement close to blood vessels, or involvement of too much liver so that you can't completely render them free of disease at 1 or 2 surgical sittings. So for patients with carcinoid metastases, a large group out of the Ohio State University with Mark Bloomston looked at hepatic artery chemoembolization, 122 patients with a radiographic response rate of 82% and a symptomatic response rate of 92%. The progression-free survival, so the time that the liver was under control without any evidence of disease progression, however, was only 10 months. So after 10 months after therapy, we'd start to see disease progress. And the median overall survival of those patients is just under 3 years. So again, decent control of symptoms or very good upfront control of symptoms, decent duration of that control, but still within 3 years the patients were getting in life-threatening situations. A very, very good liver surgical group out of France looked at staging surgical resections, so going in, addressing half the liver in the operating room, coming back and then addressing the other half. And how effective is that? 23 patients who they were able to go to the operating room out of 41 that they evaluated. 3 patients at the time of surgery were not able to be resected because of too much disease, and a single patient fell off the study because they had progression between their 2 surgical procedures. But in the circumstances where aggressive surgical resection was possible, and an R0 resection, meaning all of the disease was able to be resected, this was possible in 14 of 19 patients. And when that was possible, 95% of patients are disease-free at 2 years and 85% are alive at 2 years. So again, in highly selective patients, controlling even extensive disease in the liver is associated with overall a good outcome. So regional therapy, which we've heard a lot about in the last couple of days, but the rationale for treating just the liver. One is you can dose escalate drugs that you cannot give systemically without too much toxicity. And this is the patient population we were talking about treating. These are all multiple lesions throughout both sides of the liver. And this is what it looks like when we were doing these in the operating room. So extensive disease in both sides of the liver. Hopefully by targeting just the liver and getting the liver isolated and delivering the drug only to the liver, you are effectively reducing systemic toxicity while giving these adequate doses of drugs. And the liver and the limb and 1 or 2 other places in the body has unique anatomy so that you can get control of the arterial and venous blood going in and out of the liver so that the rest of the body is not seeing these high levels of drug. And the other thing is that with this type of procedure, versus ablative or even surgical resective procedures, and I'm a surgeon, so if they're surgical resectable, they go to the operating room first, absolutely. But we're treating the entire diseased organ. So if someone has 3 lesions, the likelihood of them only having 3 to 4 lesions in the operating room is very high. If someone has 15 lesions when you're going to the operating room, the likelihood of them having 20 to 25 lesions, so many more lesions, increases. And so in patients with much higher volume disease, there's frequently disease that you can't see. And that's why we think it's very important to treat the entire organ. For about 10 years, my partners and I at the NCI used to do this in the operating room, and this involved 2 bypass circuits, and just very quickly, the liver would be put on cardiopulmonary bypass, and for 60 minutes, high doses of a drug called Melphalan would be put into the liver. In order to do that, you have to clamp off the major vessels of the body, so the patient would then have to go on veno-veno bypass to shunt the blood from below the liver back to the heart, so that the patient would have good blood flow control. It involved a very large surgical procedure and usually took 8 to 12 hours, and patients were usually in the hospital for 2 weeks. But it worked. And if you look at these patients who were not eligible for surgical resection, were not eligible for ablation, and had very significant disease, The median overall response was 50%, so half the patients responded to the therapy. That means reduction, this was back in the old criteria days, so reduction in their volume of disease by 50% or more. And the median time of survival in these patients was 52 months, so just under 5 years in patients who were not amenable to other therapies. So we felt that this was an adequate proof of principle. However, it was still a rather toxic procedure to go through, and a lot of patients with neuroendocrine tumors have a lot of disease in their liver and may not be completely able to tolerate such a large procedure. So we started looking at a way to do this minimally invasively, and this is the device which is under FDA examination now in 2 trials. But essentially, it's a catheter that goes in the vena cava behind your liver, and we blow up 2 balloons so that all the blood that comes out of the liver, we can then isolate, run through charcoal filters, and give back to the patient. This is done through 2 groin sticks. They're actually both on the same side, but schematically we have them separate side. So we give Melphalan in high doses into the liver. It goes through the liver. When it comes out the back end, it's filtered between these 2 balloons, brought out, and given back to the patient. This takes about 3.5 hours in the interventional radiology suite, and the patients go home the following day. So much different than a 2-day ICU stay and a 10 to 12-day hospitalization. And what we noticed is that you can very effectively isolate the chemotherapy with this system. Not perfectly, but very well. And so here is the Melphalan given, and these dots up top are the systemic levels. And then you can see that there are levels, this is the hepatic levels, and these are the systemic levels. So there is a small increase in exposure of systemic bone marrow to the drug, and so patients do get transient amounts of chemotherapy exposure. But in general, patients are able to tolerate therapy every 30 to 35 days, and they get a total of 4 treatments with this drug. Now, the patients I'm going to talk about now were all treated under an NCI-IRB protocol, meaning that they were prospectively enrolled in a database so that all patients treated with this we would follow under the auspices of the FDA and our IRB. The inclusion criteria were very straightforward. Non-resectable hepatic metastases from a neuroendocrine tumor. Limited or treatable extrahepatic disease was allowed. In fact, we have 7 patients who have subsequently gone to the operating room and have had the disease outside their liver resected once their liver tumors were controlled. And they had to have adequate hepatic reserve. And these are pretty liberal criteria. So a bilirubin less than 3 and sort of standard liver function with regard to blood clotting numbers, but up to 10 times normal liver function tests. So patients with significant disease were allowed on the trial. And the only real true exclusion we had was that they had portal hypertension, so the liver was too diseased to allow the blood to adequately flow into it, or if we could not get access to the arteries, then the patients could not be treated. And in fact, in 112 patients we treated on a variety of histologies, only 3 patients have not been treatable by these criteria. So what do we see? In the 23 patients that we have treated, the median number, or the average number of lesions in the liver is 15. The average size of the largest lesion is just under 5 centimeters, and 9 patients out of 23 have had disease outside the liver, and 7 of those patients, once we induced a response in their liver, then went to the operating room and had their disease outside the liver resected so that they had no disease outside the liver. The amount of liver disease, 25% of patients, half the patients had less than 25% of their liver replaced with tumor. But a quarter of the patients had over half their liver replaced with tumors, so really not amenable to surgical resection. The majority of these patients are pancreatic neuroendocrine tumors, and that sort of reflects the bias of our referral basis at the NCI, and a small number of patients have carcinoid disease. The schema which I just touched on, patients would get evaluated with CTs and MRI, have 2 treatments 4 to 5 weeks apart, and then have an interval evaluation. If they had stable disease or responding disease by imaging, which was then backed up by tumor markers, then they would get an additional 2 treatments and subsequently be followed. So what we saw in 23 patients, we have 4 patients who we consider not evaluable. One patient had, for a variety of other endocrine-associated diseases, only had 1 treatment, and she went on to other therapies, and really the general anesthesia was too much for her to tolerate. One patient, when he was supposed to be evaluated, his liver transplant became available, so at the time of his transplant, the majority of his tumors were dead, but we don't consider that to be an evaluable patient. And we did have 1 toxicity, which I'll talk about later. Only 1 patient progressed while on therapy. And 3 patients had what we consider stable disease or a minor response, so no increase in their tumor, but not enough decrease to consider them a partial response, and that means a 30% reduction in their tumor. Interestingly, one of the patients who we consider stable disease had 25% reduction in her liver volume, normalization of her tumor markers for 39 months. So I think that was a real anti-tumor efficacy. But we had 13 partial responses and 2 complete responses, so 80% of the 19 patients we can evaluate had responses to therapy. And what this type of graph does is show you is 0 is the baseline which any individual patient started at, and the blue line represents their maximum response. So here's the one patient who grew while on therapy, and here's one of the patients who had stable disease, and another patient had stable disease, and the rest of these bars indicate the degree of reduction of their tumor volume. So the median Melphalan dose, or the average Melphalan dose we gave patients is 180 milligrams. That is equivalent to a bone marrow ablative dose. If you got that into your vein, it would ablate your bone marrow so that you could get a bone marrow transplant. So very high doses of Melphalan. Unsuccessful therapy. 2 patients had unsuccessful therapy. 1 patient had had a lot of previous intra-arterial therapies and had a very sclerotic or a very diseased hepatic artery, and we couldn't safely get a catheter in. And one of these is a patient who had very significant parathyroid disease, who was one of the ones I just talked about, who her parathyroid disease flared so significantly with general anesthesia we weren't able to safely treat her again. And this is early. A lot of these patients were treated early on in our study, and the average length of stay in the hospital was 3 days. At the NCI, we had a lot of patients from out of town, so they tended to stay an extra day in the hospital. Everyone would get admitted the night before, and they had to stay for 48 hours to get serial blood draws to look at drug levels. But right now, the average patient who lives local is going home the next day. Toxicity is not insignificant, but it is very manageable, and it's associated with 2 things. One is associated with the procedure itself, and you can have a smattering of small anaphylaxis to the drug, and 1 patient who had a brain met had a small hemorrhage associated with the brain met. The only time we saw it was at the time when they had scans. The majority of patients do have their platelet count go down around the procedure, but we found out that that's somewhat reactive, and by the evening after the procedure, it's already back up. And we have had 2 patients, very, very minimal hepatic toxicity. And we had 1 patient who the only significant toxicity did not immediately reverse was a patient who had a previous Whipple procedure, and because they had severe cholangitis after the procedure. And so right now we're not treating patients who have had previous biliary tract surgery with reconstruction of their biliary tract, at least now on the protocol. 2 patients had infections of their gallbladder, and 1 patient had an ulcer. Those are issues which we subsequently have addressed. It is chemotherapy, and patients are getting systemic exposure to chemotherapy, and so that there are about half the patients about 2/3 of the patients need to get their Neupogen to support their bone marrow function between procedures, but it is not a cumulative toxicity, and patients are able to undergo multiple treatments. Overall, we've now, these numbers, if we look at just the mortality rate, so the death associated with this procedure, an invasive procedure, is either, if we look at the number of procedures performed, it's about 1% of all procedures are associated with a patient death, which is about the same as a major liver center. And in 103 patients, and this is now 130 patients, we've had 3 deaths associated with the therapy. So how does it?
5 minutes.
Yep. How does this work? How well does this work? If we look at the hepatic progression-free survival, so the duration of response for patients, within the liver, we see that the average response holds for approximately 39 months before we start to see regrowth of tumor. And if we compare that to the embolization data, which was 10 months. And then if we look at overall survival in all 23 patients who were treated, including the patient who did not respond and the minor responses, the median overall survival is 40 months, so greater than 3 years in patients with unresectable, unablatable tumors. So we think a pretty good response, overall survival rate in a very sick group of patients. Just quickly to show you what type of responses and the type of patients we were treating. This is a patient who we evaluated, and when we performed a laparoscopic exam, the entire liver was filled with these large glucagon-making metastatic neuroendocrine tumors of the pancreas. Her primary tumor was in place, but it was unresectable. And this is the angiogram of her liver, and all these round spots represent tumors. And here's her glucagon level, her glucagon, which was measured in her hormone in her blood. And if you see that after she had 1 treatment, the level started to drop, and after she had 2 treatments, the level dropped, and when we scanned her, it looked like she had a good response, but we weren't sure why. Her levels were starting to go up, but her tumor, her primary tumor had never been treated, so we treated that with radiation, and then subsequently her hormone levels went down to 0 or to normal, and she never had any additional therapies. In fact, she died 2 years after we initiated treatment, and when she died, it was of recurrence of her primary tumor, and at the autopsy, she had no visible disease in her liver. So here are scans. If we could have the lights down just for a second, but you can see here, this is what things looked like before, and you can see multiple lesions throughout the entirety of the liver, very significant large lesions. And here we are immediately after her second treatment with some areas of residual cystic changes around the tumors. And then here we are at 22 months with, again, small cystic changes in scattered parts of her liver, but a very essentially normal-looking liver throughout. And one final patient, this was a young male who we treated with widely metastatic disease, and you can see multiple tumors throughout the entirety of his liver, close to the vessels, not resectable. And here, because he was quite ill, we decided to get scans after the first treatment. If we weren't doing any good, we would have changed to another therapy. But already after one treatment, you can see a significant decrease in the size and number of lesions. And subsequently, after his second treatment, before resecting his primary tumor, you can see that there's minimal sort of shadows of where his tumors used to be, but effectively no active disease. So in conclusion, we think that high-dose Melphalan is delivered intraarterially is effective against hepatic metastases from neuroendocrine tumors. Not only do we see reduction in the tumor, but in every patient who we've seen a response, it's correlated with reduction of symptoms and hormone status. And at present, we have this data in front of the FDA looking for either a multi-center phase 3 or a phase 2 trial to confirm these results with the goal of having this as an approved protocol for standard of care use. Thank you very much.